friends, hi, this is Dr. Shonali Chandra. I received requests to discuss the Partogram, so that is what I will be doing in this video. So let's begin. So the Partogram is used for the monitoring of labor. It's a tool for that purpose. And monitoring of labor is important because we want to identify any delay or arrest in the progress of labor so that we can act accordingly. I will be discussing this with the help of a clinical scenario. And before moving on to that, I will briefly review how labor progresses clinically under normal circumstances, because until unless you know normal, you cannot differentiate what abnormal is, right? And then I'll talk about what exactly is in a Partogram and how is it plotted and used as a monitoring tool. And thereafter, I will be talking about the clinical utility of the Partogram, meaning we will see how it helps us to identify delay or arrest in the progress of labor. So let's answer the first question, how labor progresses clinically. Now we know that initially the cervix is long and the os is closed. Once the uterine contractions start and beginning of labor happens, it is these contractions which are the driving force behind labor. The contractions which are going to push the baby's head down, and it is the uterine contractions which are going to help in effacement and dilatation of the cervix. So as the labor progresses, the cervical length shortens, right? So it gets effaced, and thereafter the cervix has to dilate from being close to about 10 centimeter dilatation. Now, this does not happen in just 3 steps. It takes time, right? So the first stage of labor, okay, is from the onset of contractions to full dilatation of the cervix. And it is divided into 2 phases. One is the latent phase, which is longer and slower, and the average duration can vary, which is about 12 hours in primigravidas and 8 hours in multigravidas. It can be longer than this also, or shorter than this also. And once the cervical dilatation reaches 4 centimeter, it is called as the active phase. Now, when the active phase begins, the clock starts ticking. Now, after this, the rate of cervical dilatation should be maintained at least to about 1.2 centimeters per hour in primigravidas and 1.5 centimeters per hour in multigravidas. Anything that is slower than this will be called as protracted active phase. Okay, and once the cervical dilatation has been achieved completely, the next thing that is left to happen is the descent of the fetal head, right? So the fetal head is going to come down into the birth canal and then delivery will take place. So most of this descent takes place in the second stage of labor, which is from full dilatation of the cervix to delivery of the baby. Now that we know this, let us see what a partograph is. Now, a partograph is a graphical representation of all that is going on with the laboring women. It contains a label with patient identifying information, also with the gravida status, parity status, weeks of gestation, and important diagnosis, basically, mainly about the pregnant lady. There is a graph where you monitor the fetal heart rate. Okay, as you can see here that there is a small box. This small box means half hour. It represents a period of half hour. So in the active phase, in low risk women, the fetal heart rate is measured every half hour. There is a graph where you have to mention the amniotic fluid. Okay, if it's leaking, you will have to see the color. Okay, if it's clearless, you mention C. If it is meconium stain, you mention M. If it's blood stain, you mention B. Similarly, molding. If the molding is present, you make a plus sign, or if it's absent, you make a minus sign. All right, and then below that you can see that there is another graph where you are plotting the time on the x-axis here, and you are plotting the cervical dilatation and descent on the y-axis here. Below that, we are also plotting the uterine contractions, right? Apart from this, you are mentioning any oxytocin infusion that is going on to the woman, any IV fluid, any medication that she is receiving. Also, we are plotting the maternal heart rate, maternal BP, temperature, urine sugar. So all these characteristics are being plotted on the Partogram. So you can have one look at the Partogram and you will know what has been going on with this laboring woman. Okay, now let us see how it is plotted. And let's say that we are in the night shift in the labor room, and a 26-year-old low-risk primary gravida is admitted with labor pains. There is history of show, but no complaint of leaking fluid. So everything normal, she's just complaint of normal labor pains. On per abdomen examination, the uterus is term size, cephalic, and she is getting 2 contractions in 10 minutes, each lasting for 10 to 15 seconds. So she is getting mild contractions. Okay, she is right now getting mild contractions. You do a PV at the time of admission. The cervix is 2 centimeters dilated, 50% effaced. There's a bag of membranes which is present, and the vertex is at -2 station. Fine. Now, you leave her at that, right? She's just been admitted. Overnight, she stays in the labor room. 12 hours later, the next morning at 8 a.m., she is still getting mild contractions, right? The PV findings are the same, but the effacement has progressed to 80%, right? So more or less, her PV findings are the same. There is no measurable change, just that the effacement has progressed. What is the diagnosis? She is still in the latent phase of her labor. How is she managed? As long as she remains in the latent phase, we have to go for wait and watch policy. Basically, we let her progress on her own. Do not do unnecessary intervention. Intervention is done only if the latent phase is prolonged. So when do we call it as prolonged latent phase? We call it a prolonged latent phase when in primary gravidas, the duration has been more than 20 hours, and in multigravidas when the duration has been more than 14 hours, right? So until unless those durations are crossed, we let her progress on her own. Wait and watch policy, we can give her rest, pain relief, sedation, that is all, right? Now, that is something that has happened at 8 a.m. Now, few hours more go by, and we see that her pains are progressing in intensity and duration. 6 hours later at 2 p.m. she is reassessed. We want to find out now what has happened after 6 hours. So now she's getting 3 contractions in 10 minutes, each lasting for about 20 to 25 seconds. So she is getting moderate contractions, okay? We repeat a PV. Cervix now is fully effaced. There is 4 centimeter dilatation. Membranes are still present. The vertex has come down from -2 to 0 station. The sutures are now can be made out, and we find that she is in LOA position. What is the diagnosis now? She has entered active phase of labor. And how is she managed? Now we will start plotting the partogram. So let us see how we plot the partogram in this case. So at 2 p.m. here, she is 4 centimeters dilated. Okay, so the dilatation is plotted as an X. All right. Now, if at 2 p.m. she would have been 5 centimeter dilated, I would have made the plot here. If she would have been 6 centimeter, I would have made the plot here. So the first plot, friends, is always to the left of the alert line. Okay, so in this WHO modified partogram, we see that the plotting begins and the active phase. There is no plotting in the latent phase. Another important thing that you can see here, that there is an action line also drawn, that is drawn 4 hours. That is drawn 4 hours beyond the alert line, parallel to the alert line. All right, so this is also there. Now we will also plot the contractions at 2 p.m. She was getting 3 contractions. So I will plot 3 boxes. Okay, I will plot 3 boxes here. She was getting moderate contractions, so I will draw slanting lines. Okay, now you can see that contractions are denoted by these small boxes. So this one small box is for half hour. So the contractions are also plotted half hourly. Okay, if she would have been getting mild contractions, I would have just filled the box with dots. And if she's getting good contractions, the box is completely shaded, right? So that is there. And the number of boxes shaded means the number of contractions in 10 minutes, right? Now, let's say we see that she progresses fine, all right? She is getting moderate contractions here. She continues to get moderate contractions, and then her contractions become good in a while. So we have started shading the box completely. right? So we are monitoring her every half hourly for contractions, and we decide to do the next PV at, let's say, 6 p.m., 4 hours later. So one big box, 2, 3, 4 big boxes later, at 6 p.m. we do her next PV. So let's say at 6 p.m. she is now 10 centimeters. So our graph has said that she has progressed fine. So as long as we remain to the left of the alert line, we are good and happy. When we remain on the alert line, it means that the dilatation is proceeding at least at the rate of 1 centimeters per hour. Okay, so when we cross the alert line, that means that the dilatation is slower than 1 centimeter per hour, and we should be concerned. Now, all this while I talked about plotting the dilatation. How do we plot the descent? Okay, now let's say at 2 p.m. initially, she is, let's say if she were -2, let's say if she were -2 station. So you realize here that the graph ends at 0. So friends, please remember that the cervical descent, the descent of the head, can only plot it from -5, -4, -3, -2, -1 to 0 station. Okay, there is no +1, +2, +3 station that is plotted on the partogram. So let's say at 2 p.m. she was at -2 station. We'll make a circle here. And at 6 p.m. if she is at 0 station, we'll make a circle here. So the descent has also progressed. So this is how a partogram is plotted in the normal circumstances. Now I will change the scenario a little bit. Let's say that at 2 p.m. she was 4 centimeters dilated. We are seeing that she's getting moderate contractions here. And at 6 p.m. when I repeated the PV, I find that she is only 6 centimeter dilated. So what has happened? The alert line has gotten crossed. Now, why is she progressing slowly? The first thing that should come to your mind is contractions. The contractions are not okay. Have a look at the contractions. The contractions which were earlier moderate are now mild. So I know that the contractions are not adequate. So now is my time to intervene. I get alerted, I intervene. So how do I intervene? I will do something to augment the contractions. What can I do to augment the contractions? If the membranes are already present, I can do ARM, artificial rupture of membranes. If the membranes are absent, I can directly start oxytocin infusion. So I can employ these two methods to augment the contractions. Let's say now I have started the oxytocin infusion here, and I see that the contractions are increasing in intensity also. They're becoming moderate and then good, and they're also increasing in number. Initially there were 3 contractions, now there are 4 contractions in every 10 minutes. So I repeat the PV now at 8 p.m. 2 big boxes later. Here at 8 p.m. I want to repeat PV in 2 hours because now I want to see whether my intervention is working or no. So I see at 8 p.m. she has reached 10 centimeters. So my intervention is successful. So this is how the partogram will help us identify a delay or protracted active phase, and then I can act accordingly because I want to identify the reason why the labor is delaying, and most commonly it is because of inefficient uterine contractions. Okay, now let us change the scenario a little bit more. Let us change the scenario a little bit more. I say that the same woman who at 2 p.m. was 4 centimeter, at 6 p.m. was 6 centimeters, and she was getting mild contractions. So I decided to start oxytocin here. I continued the oxytocin for another 1-2 hours. All right. And at 8 p.m. I find that instead of progressing, she is still stuck at 6 centimeters. So now, friends, I have reached the action line. I've reached the action line, and I see that yes, the contractions increased, but they have not been enough to do any change in the cervical dilatation, right? So now I'm very worried, and I start thinking about the 3 P's, very, very important 3 P's that you have to think about: the power, the passage, and the passenger, right? The power refers to the uterine contractions. Only that is under my control. I can only increase the contractions. Passage, the birth canal, whatever the size of the pelvis is, it is. I cannot change that, right? What about the passenger? Sometimes when the fetus's head is larger as compared to the pelvis, right? That is something that is called as cephalopelvic disproportion. Sometimes there can be a larger fetal head which causes a cephalopelvic disproportion. Sometimes there can be a deflexed head in which larger diameters try to enter the pelvis. Sometimes there can be a malposition like ROP position. Sometimes there can be malpresentations. All of these contribute to delay or arrest in progress of labor, right? So under my control during labor is only power. I can only increase the power. I can only increase the uterine contractions with the hope that with the mild CPD, probably with the force of contractions, head comes down. A deflex head could get flexed. All right. In ROP position, I would hope that with contractions, anterior rotation will take place, right? So basically, in my hand, only power is there. So right now, when I was thinking about the 3 Ps, I am still wondering what should I do. So I decide to give her another 2 hours of good uterine contractions. So she's getting good contractions. I decide I would wait and watch. And at 10 p.m., she is still stuck at 6 centimeters. Now what has happened? She has gotten almost 4 hours of good uterine contractions. 4 hours of good contractions, and there is still no change in cervical dilatation. This is what we call as arrest. This is what we call as arrest of dilatation. So we diagnose arrest when there is at least 4 hours of good contraction and there is no appreciable change in cervical dilatation. Okay, now let's talk about another clinical scenario. Let's change it a little bit more. Let's say that at 2 p.m. she was 4 centimeters dilated. At 6 p.m. she was 6 centimeters dilated. Contractions were inadequate, so I gave oxytocin infusion, started here. I reassessed at 8 p.m. The dilatation progressed to about 7 centimeters, still slow blood progressing. So I continued further. 10 p.m. she is still 10 centimeters. She has become fully dilated 10 centimeter, fine. But there is some problem here, friends. The descent from -2 here came down to 0 at 6 p.m. Fine. At 8 p.m., the descent is still stuck at 0. At 10 p.m., the descent is still stuck at 0. So she has managed to dilate, but the descent is not progressing even with good uterine contractions. All right. So what can I do now? Can I still wait? Yes, I can still wait as long as the mother and baby are doing okay. So I decide to, let's say, wait for another 2 hours. Wait for another 2 hours and reassess her at 12 p.m. At 12 p.m., I find that she is still stuck at 0 station. No change in station has happened and the contractions are still good. The contractions are still good. So there have been good contractions for 1, 2, 3, 4 hours of good contractions here, but there is absolutely no descent happening. All right. On the other hand, on PV, we note that there is a caput formation. We note that there is molding that is happening. Okay. Especially grade 3 molding. Okay. Women's bearing down efforts are also good. Despite that, there is no progress in descent. This is what we call as arrest of descent. This is what we call as arrest of descent. All right. So when there is no change in descent, along with good uterine contractions, we call it as arrest of descent. All right. Now, how long can we wait in this case? So you see here, we can wait for about 3 hours in primigravidas and 2 hours in multigravidas, as long as the mother and baby are doing okay. If the PV is showing findings of caput, molding, grade 3, or features which are suggestive of CPD, these are features of CPD, then I will have to act earlier. Then I will not wait for 3 hours. I will have to act earlier because CPD is there. All right. So if arrest of descent happens, then the next management is a cesarean section. At 0 station, I cannot apply any instruments. So I will have to expedite delivery, but I will have to see what is the best course of action. Whether I could apply a vacuum or forceps, or whether I will have to go for a cesarean section. By any of the two means, I have to expedite delivery because arrest of descent has taken place. So this is how the partogram is plotted, and this is how it helps us to identify delay in progress or arrest in the progress of labor. Okay. So I hope you find this video useful, and if any doubts, you can ping me. You can post your doubts on the Telegram channel, or you can also post your doubts on the YouTube video as well. Thank you.